Let's see. All right. Welcome, everyone. And thank you for joining us for today's webinar hosted by the North Carolina Medical Society and the North Carolina Medical Group Managers Association. I am Kristen Spaduzzi, and I'm the Director of Health System Advocacy with the North Carolina Medical Society, and I am thrilled that you guys are all going to join us today. The NCMGMA's mission is to maximize the value and effectiveness of medical practice leaders through educational programs, information exchange, networking, and professional development opportunities. The NCMS mission is to provide leadership in medicine by uniting, serving, and representing physicians and their healthcare teams to enhance the health of all North Carolinians. The NCMS and the NCMGMA work collaboratively to provide these bi-monthly webinars for our members. And in each of our shared educational opportunities, we embody these two missions. We welcome your feedback and suggestions for future webinars and any feedback that you have for today as well. Today's presentation is focused on the No Surprises Act and will be presented to us by Attorney Joy Hord from Parker Poe. And throughout the presentation, please keep your microphones muted. You can submit questions in the chat box, and we plan to have some time at the end of the presentation to answer your questions. We will be recording this presentation, which will be posted on the NCMS webpage and the NCMS YouTube page, and we'll push it out through our daily bulletin morning rounds and I believe through the NCMGMA blog. So without further ado, I will pass the proverbial mic over to Joy Hord. Thank you, Joy.
Thank you. Thanks, everyone. And thank you to the Medical Society and North Carolina MGMA for inviting me to do this presentation. I know this is an area of law that is on a lot of people's minds. It is an area of law that is evolving quickly. I will be sharing a couple of things that have happened in just the last week or two as part of the presentation. So with that, I will get started. So quick, well, there we go. Quick disclaimer, I'm not going to read this to you, but I am not your attorney. So unless I am your attorney, because I do see some clients on the phone, but participation in this presentation does not create an attorney-client relationship. So please do not email me after this presentation with a specific question that you have. If you want to reach out to me after this presentation about a potential engagement to help with things, I'm always happy to help with you, but please don't send me very specific information about a concern you have after this presentation by email or leaving me a voicemail. And then the No Surprises Act disclaimer number 2, I'll hit on this some more during the presentation, but this is a evolving law. There have been published rules that have been published as what are called interim final rules, which means they are likely to change. And then there are proposed rules also likely to change. Additional guidance is being published almost weekly from some of the regulatory agencies. I'm going to highlight one of those that came out week before last as we chat. So anything in this presentation today, I think is up to date as of today. However, just know that you'll need to stay on top of this as additional rules are finalized and additional guidance is issued. So a quick regulatory and statutory background. The No Surprises Act was passed as part of the Consolidated Appropriations Act of 2021, which was passed in December of 2020. So the law is final. The law has been adopted and we know what it says. There have so far been 3 interim final rules issued in July, October, and November. And I've included on this slide the topics that were addressed by each of those interim final rules. Just as a bit of Law School 101, typically when a regulatory agency issues rules, it is required to issue those as proposed rules first, solicit comments, and then issue final rules after having the benefit of having the affected industry weigh in on what the rule should state. In this case, however, the entities that published the rules relied on an exception, which allows rules to be published in final form without an initial comment period if they can show good cause. And in this case, the good cause was it was impractical and contrary to the public interest to delay getting the rules out. So these interim final rules are final, meaning that they're binding today. However, when they were published, they ask for comments to come back to the issuing agencies. And so those interim final rules are very likely to be revised over time. And just so you know, the comment period on all of those interim final rules have passed. However, I continue to see lots of associations, and I don't think I saw any from the MGMA, but I'd be surprised if there aren't any, continuing to send letters of concern to the regulating agencies asking for more guidance. There is a proposed rule that was adopted in September 2021. It is not in final form, so it is not currently binding, though I will tell you that those rules did not impact physician practices. So I won't touch about very much on those. And then, as I've mentioned, there is guidance and frequently asked questions being published by the regulating agencies, almost, it seems like, on a weekly basis right now. So why was the No Surprises Act adopted? There were two primary goals to be accomplished, though I think the driving force regarding why it was adopted was a concern with balance billing. And so to put that in context, balance billing occurs when an out-of-network provider provides services to an insured individual. And after insurance pays whatever it will pay under its contract with the patient or the patient's employer or the patient's, with respect to that service, the out-of-network provider can then balance bill the remainder, what wasn't paid by the insurance company, to the patient. And those can be pretty shocking amounts, particularly when someone receives services from an out-of-network provider for a significant hospital stay or for drugs that were super expensive. The one that seems to get the most airplay kind of in the public is about air ambulances. A cost in an air ambulance, so a helicopter ride to the hospital, can be incredibly expensive. We're talking tens of thousands of dollars, and air ambulances tend to be out-of-network providers. So lots of the stories you may see in the press about why this law was adopted talk about someone that was in an accident in a rural area, is airlifted to a hospital, and after everything is settled with the hospital and the surgeons and anyone else, all of a sudden gets this bill for the air ambulance ride, which is enough to bankrupt lots of folks. So that it's the air ambulances that get the press, but there's a lot of instances where balance billing was, could impact insured patients ending up with a significant balance bill that they're required to pay. The other purpose that the No Surprises Act is intended to address is to provide patients with information to be their own consumer advocates. So that is a lot of what this presentation focuses on, is how patients get that information, and in particular, the role that physician groups provide in getting that information to the consumer patients. It's important to know that this law did have bipartisan support. If you look back at the effective date or the adoption date, that was within the Trump administration. This is not a Biden approved law or adopted, a Biden administration adopted law. And the other thing it addresses is some states had regulation in this area, but it was fairly inconsistent. For those of you on this call that work in or have practices primarily in North Carolina or South Carolina, North Carolina and South Carolina had not yet adopted Surprise Billing Act regulations. However, some had been proposed and perhaps would have been adopted had there not been something that happened on the federal level. States are also limited in what they can require certain insurance plans to provide, particularly those of self-insured plans. So when an employer, for instance, has its own self-insured plan, states have limited ability to regulate what those can do, but the federal government can. So that's just a quick why it was adopted and how it was adopted. So who does it regulate? Different parts of the No Surprises Act apply to private insurance like Blue Cross Blue Shield, Cigna, or Aetna. Self-insured plans, so those are typically employer-sponsored plans where the employer is assuming some risk. Healthcare facilities and providers, including physicians. I listed air ambulance providers separately. I recognize that they are a healthcare provider. However, there are some provisions of the law that are aimed at air ambulance providers, specifically trying to get at what was seen as abusive practices of balance billing. Important to note, however, none of what I'm talking about today applies to federal payers or services provided to Medicare or Medicaid patients. In essence, the assumption is that there are no surprise bills for Medicare, Medicaid patients, so they did not need to be covered by this law, nor did all of these entities, the private insurance, self-insured plans, physicians, or air ambulance providers need to do anything to protect Medicare, Medicaid patients from surprise billing. And then from this point on, I just wanted to let you know that this presentation is focused on regulations applicable to healthcare providers and specifically to physician groups. If you work for a group that is also a self-insured plan or has a self-insured plan for its employees, I am not touching on those regulations today. So just know that if you work for a self-insured employer, that you're going to need to investigate what No Surprises Act requires of you for a self-insurance plan separately from this presentation. So how does this interact with state law? I'm going to move through this very quickly because North and South Carolina do not, in fact, have state laws that we need to worry about. But the bottom line is that this works a whole lot like HIPAA does in terms of how the federal law interacts with the state law, in that if state law is seen as more protective of patients and consumers, then the state law continues to apply, but it applies on top of the federal law requirements. State law cannot trump any provision in the federal law, but it can add additional protections for patients. So how does the law propose to protect patients? I touched on this earlier, but the two areas that it's really intended to provide and how the rest of this presentation is organized is looking at patient protection that is intended to address the total cost of care. And really what that comes down to is limitations on balance billing. And then the second part is patient education. And if you've been following this area of law, lots of the things you will have read about is about the obligation to provide a good faith estimate of cost to patients. And that is the second part of the remainder of this presentation is going to focus on that patient education component. So how do those specifically impact physician groups? So the patient protection portions most likely impact facility-based providers like anesthesiologists and radiologists, surgeons and other doctors providing services in a facility. So facility includes hospitals, ambulatory surgery centers, outpatient departments of hospitals, freestanding emergency rooms. A facility is not your physician office. So when I'm talking about the limitations on on balance billing and patient protection, know that it is only applying to services that are provided in a facility. So if you are work with a group that your doctors rarely, if ever, go to the hospital or to an ambulatory surgery center or to an emergency room to provide services, the patient protection provisions of the No Surprises Act likely have little or no impact on you. The patient education portions, however, apply to all physician groups. And when I get to that second part of the presentation, the two big pieces are your requirement to post patient notices and then to provide that good faith estimate. So patient protection, and this is again the limitations on balance billing, it applies in just two situations. A patient seeks emergency care at an out-of-network facility. And then the second instant is the patient seeks care, so it could be emergency or non-emergency, at an in-network facility, but some of the providers or services that are provided by out-of-network providers. So, for instance, patient arrives by an ambulance to receive emergency care at an out-of-network facility. The protections against balance billing that I'm going to talk about in more detail in the next slides apply to all services that patient might receive, whether from the out-of-network facility or from any provider at that facility that relate to the provision of emergency care. The second scenario in which this applies is the patient goes to an in-network facility. So the patient has done what they're supposed to do, which is to know that they need care. So this is and they look and see, okay, patient A, facility A is in network, facility B is out of network. So I am going to schedule my ambulatory surgery procedure or my hospital visit or my newborn delivery at facility A. However, once they get there, they encounter providers or services that are being billed by out-of-network providers. So those are the two scenarios where balance billing applies. As I already highlighted, it does not apply. The balance billing protections do not apply to services you provide in your office unless you happen to have an ambulatory surgery center as part of your office. So how it applies. So for emergency care, an out-of-network provider cannot bill the patient more than the patient's in-network cost sharing amount. So there is no ability to balance bill in cases of emergency care. In some cases involving non-emergency care, however, out-of-network providers can balance bill with the patient's advance written consent. So, for instance, you are scheduling a surgery with a patient. You are out of network with the facility where the patient is going, but the facility is in network. There are circumstances where, with the patient's consent, you can balance bill the patient. So you can send the patient a bill for the remainder of your charge after the insurance company pays whatever it's going to pay for the service. Otherwise, in both of these cases, so always for emergency care and in non-emergency care, unless you can use the consent process and follow the consent process, the total amount that you're going to receive for that care provided in the facility is billing the patient for their in-network cost share and then a negotiated payment from the insurer. And that the process for getting to that patient negotiated payment from the insurer, called the IDR process, is one that has gotten a lot of press, and I will touch on in this presentation. So I am back to the discussing in what situations you may be able to bill the patient if you are out of network for non-emergency care that's provided in an in-network facility. First of all, there are situations where you are just out of luck. You can, even if you inform the patient that you are out of network, you still cannot bill or balance bill the patient for charges if the services you are providing are on this slide. Those include emergency medicine, anesthesia, pathology, and radiology, services by hospitalists and intensivists, certain diagnostic services such as labs or radiology. And then if you are the only provider in that facility who provides the services, you cannot balance bill. So the patient, if the patient is at an in-network facility to receive the services, and let's say that you are an ENT surgeon, and you are talking to the patient and explaining to them that you are out of network, unless there is an in-network ENT surgeon that could provide that service at that facility, you are not allowed to go through this consent process to request permission to balance bill the patient. The process, assuming that you can go through the consent process, there are very technical requirements regarding what the content has to include in that consent. You must incorporate a good faith estimate into that consent process. Typically, you have to obtain that consent at least 72 hours in advance of the procedure or service to be provided at the in-network facility. And the patient can revoke, even if you get the consent, the patient can revoke it at any time up to the time of services. There is a later slide where I reference the forms that have been published by CMS. And those are going to be published on the North Carolina Medical Society's webpage. So I've included links in the presentation, but those will also be posted on the Medical Society website. So don't worry about when we get to that slide copying down the links. But the form that has been provided by CMS for the consent process, you have to follow that form exclusively. You must use that form. There is very little leeway to change that form. So again, if you are an out-of-network provider providing services at an in-network facility and you are trying to get consent to balance bill the patient, make sure you use the approved CMS form. So we are now at the point that you are subject to the balance billing prohibitions. So you have not obtained a consent. And we are talking about how the final payment that you receive from the insurer will be determined. So you can bill the patient again for their in-network cost share responsibility. With respect to getting paid for the balance of the bill for the insured patient, it is either through agreement between the provider and the insurer, or you can use the independent dispute resolution process that is provided for in the regulations. So the way that the independent dispute resolution process works is that the plan or the insurer must make an initial payment to you. So you submit a bill for your services to the plan, and the plan makes an initial payment. There is then a 30-day open negotiation period if you, as the provider, the physician, elect not to accept the initial payment as payment in full. If those negotiations fail, so you've received the payment, you don't think it's a fair amount, you would notify the payer, and then there is a 30-day negotiation period. And you have to wait until the end of that 30-day negotiation period to invoke the next resolution process, which is the IDR process. If negotiations fail, then either party can invoke that independent dispute resolution process, and you use a certified independent dispute resolution arbiter to determine the final payment amount. In terms of finding a certified IDR arbitrator, you cannot just pick one from anybody on the web that claims that they are an IDR. There is actually a list of the approved IDRs on the CMS website. Their fees right now range from about $300 to about $500 for resolving a single claim. So obviously, if you are fighting with a payer over $50 or $100 or $200, you likely, this is intended to drive you to resolve that amount, because otherwise the fee alone is going to exceed the difference between what the parties were able to come to through the 30-day the negotiation process. In the end, unless the parties agree otherwise, the losing party is going to pay this fee. So just a quick note, when the independent dispute resolution process starts, each party typically pays 50% of the arbitrator's fee. However, at the end, as part of the final determination, the arbitrator will assign the responsibility to pay the balance of the arbitrator's fee to the losing party. So if, for instance, each party paid the arbitrator's fee was $300, the payer and the provider each paid $150 of that at the beginning, the provider prevails, then not only is the provider entitled to the higher payment, they are also entitled to require the payer to pay them the $150 that they paid up front for the arbitrator's fee. There is also a process for, if it's not a single claim, there is also a process for submitting the more than one claim at a time. I called it the bundled process on here. It's actually called, the technical term in the regulations is called batching. So you can batch claims to be determined by an arbitrator at one point, and the CMS website that includes the fees for arbitrators does include a different fee when there are batching of claims as opposed to a single claim to be determined. And really interesting about this process is that it uses what's called baseball arbitration. So the arbitrator must select one of the proposals. So the provider comes and says, we think that $2,000 is a fair total amount to be reimbursed for this service. And maybe the payer comes and says, I think $1,200 is fair payment for this service. The arbitrator has to pick either $1,200 or $2,000. It can't average. It can't meet in the middle. It can't encourage the parties to continue negotiations. It just has to pick one of those numbers. So when you trigger that independent dispute resolution process, one party triggers it by providing notice by selecting an arbitrator and notifying the other party. As soon as that process starts, both parties must submit their payment proposal within 10 days. So in the scenario that I just used as my example, the payer is saying we think payment is $1,200. The provider is saying $2,000. Both parties must get that number to the arbitrator within 10 days of the selection of the arbitrator. The parties can submit additional information for the arbitrator to consider in that 10 days. And I've included here what the arbitrator can consider and what the arbitrator cannot consider. And then there is a 90-day no repeat period. So for instance, if in my example, the dispute where the payer is offering $1,200 and the provider is proposing $2,000, if the payer and provider, there is later a situation where the no balance billing rules apply with the same payer and the same provider for the same code. So for the same CPT code or procedure code, there is no appeal right for 90 days. So you could not appeal and try to get a different result with that same payer for the same procedure or the same service within that 90-day period. So a lot of the concerns about the IDR process related to something called the qualifying payment amount. And I'm going to tell you what that is, even though it has now been eliminated as the result of a fairly recent case in Texas. So the interim regulations proposed a method to calculate the qualifying payment amount, or QPA. And that amount was seen as the median rate the insurer would have paid for the service if it had been provided by an in-network provider or facility. So in my example, let's assume that the QPA the qualifying payment amount is $1,300. If that is the case, then the default before this Texas lawsuit was that the arbitrator would have to select the offer in arbitration that was closest to the qualifying amount, though other permitted factors could sway this decision. But the default rule was that the arbitrator would have to select the amount closest to the qualifying payment amount. So in my situation, absent extenuating circumstances, the arbitrator would have to default to the $1,200 proposal from the payer, as opposed to the $2,000 proposal from the provider, as the $1,200 would be closest to the qualifying payment amount. That portion of the rule was eliminated by this recent case in Texas. And one of the things that if you're looking at your if you're looking at your emails, your texts right now, pay attention, because here's something really important. Lots of providers may have decided not to appeal because they were concerned about this qualifying payment amount and were concerned that there was really no reason to appeal because the qualifying payment amount was going to be so close, or was maybe even the amount that the payer had offered to pay already, that there was no reason to invoke the independent dispute resolution process. So in light of the fact that part of the interim rule could have impacted the decision by providers to not invoke the independent dispute resolution process, CMS just opened up a 15-day period where providers can go ahead and invoke the independent dispute resolution process, even though the window to do so closed a long time ago. So we're talking about claims that, for claims for services that may have happened in January, February, and March, your period of time to invoke the independent dispute resolution process may have already passed. However, there is this 15-day window that just opened up, and I think it opened up as of Friday. So that means you've got 15 business days. So you have 3 weeks from last Friday to decide, now without that default rule about the qualifying payment amount, I am going to invoke this dispute resolution process. So that slide was the final one with respect to the patient protections portion of the presentation. And as I said, that part of the presentation really focused on when you can and when you cannot balance bill. And in situations where you cannot balance bill, how is the final payment you're entitled to calculated? So I am now moving on to the patient education portions of the Surprise Act. If you have not been if you've not been paying 100% attention to this presentation because up until now, because your doctors are not in facilities very often or not at all, I'm now asking you to start paying attention again, because the rest of this presentation applies to all physician groups, regardless of whether your physicians are in a facility providing services or not. There are 2 separate requirements related to patient education. One is the obligation to provide a patient notice, and the other is an obligation to provide a good faith estimate for uninsured and self-pay patients regarding what the cost of coverage are going to, their costs of care are going to be. So patient education, the patient notice must inform patients regarding the balance billing protections, so all of that stuff we just talked about, their right to receive a good faith estimate of the total costs of care, which the next slides are going to talk about, and how to report a violation if they believe that either the balance billing protections or the good faith estimate obligations have not been followed. That notice must be posted in 2 places. It must be posted on your website, and it must be posted, unlike HIPAA that requires it to be really front and center, the regulations do not require it to be front and center, but it must be something that can be searchable. So if you have a search feature on your website, if someone types in No Surprises Act or good faith estimate, this notice needs to pop up. And then it also has to be posted where individuals schedule care, check in for appointments, or pay bills. Now, if you're a provider, a type of provider that does not have a publicly accessible location for patients, that second posting obligation does not apply to you, but it still should be on your website. There is a CMS form of notice, and it is, I'll get to a link to that form in a few minutes. This is a proposed form of notice. You are not required to follow this notice form exactly. However, I'll tell you, it's really well done, and I'm not really sure why you would change it, because it's fairly short and sweet and incorporates the requirements that the regulations are going to require you to incorporate anyway. So unlike the form that we spoke about a few minutes ago, in terms of the form, the CMS published form about how you can get a patient's consent to balance bill in certain circumstances, and you must follow that form. This form is not, you can change this form. It is not a mandatory form. So the obligation to provide a good faith estimate, that obligation must include an estimate of all charges for all care, and not just by the provider or facility preparing the good faith estimate. It must include a list of the expected goods and services, and it must include a list of the related diagnosis codes. There was guidance published by CMS on April 5th, answering a lot of very specific questions about content of the good faith estimate. I think it was a pretty good FAQ addressing specific situations. So, for instance, what if you're providing a good faith estimate for a patient that is coming in for the first time and you don't have a diagnosis code yet? One of the purposes of this visit is to diagnose what might be going on with the patient. Well, in that case, you don't have to provide the diagnosis code. So that's the sort of guidance that is in that FAQ that was just recently published. And I also have a link to all of that guidance at the end of this presentation. There is a sample CMS form for the good faith estimate. Like with the patient notice, it is simply a sample form. You do not have to use that form. If you are already providing a form to patients that largely tracks many of the obligations of the good faith estimate, you can certainly take that form and revise it to incorporate the requirements of the good faith estimate. But the link to the form is at the end of this presentation if you want to use it. And one of the good things about using the form is you no longer have to worry about whether you've met all the obligations of the statute and regulations, because the form does. In terms of timing, it must be provided the earlier 3 days after requested by the patient, or at least 3 days in advance of the services that are being scheduled. And then, you need a chart of if, when. It also, if the services are scheduled more than 10 days in advance, it must be provided within 3 business days of scheduling. If the services are scheduled within 3 and 9 days in advance, it must be provided within 1 business day of scheduling. If there are updates to the good faith estimate, new facts become available, because there's some screening done of the patient pre-surgery, and you realize that there's an additional procedure that will need to be done, or some additional preoperative care. There is a defined process for the timing and contents of updates to that good faith estimate up until the time the services are provided. So the good faith estimate, for purposes of self-insured patients, or patients who are insured but electing not to use their insurance, must be provided by the convening provider. And the convening provider is the provider facility that schedules the item or service, or who receives the initial request for a good faith estimate. So, for instance, let's say that someone is pregnant, trying to figure out the cost of delivery, may reach out to the hospital and say, I anticipate delivering in your hospital. 6 months from now, I would like a good faith estimate of all of the costs related to that delivery. In that case, it would be the hospital that would be required to provide the good faith estimate and reach out to all of the other providers involved in that care. So the OB, the anesthesiologist, labs, and get a imaging and get an estimate for what that delivery may cost. The hospital in that instance would be required to reach out to the other providers and to include their cost on the good faith estimate. And those other providers so for instance, if you're an OB group and received a request from the hospital, you have to provide that information within 1 business day of request. Lots of times, this obligation to provide the good faith estimate is going to fall on the physician practice, because the physician practice is going to be the one scheduling the service or procedure. Again, this good faith estimate, I keep talking about services in the hospital, but this good faith estimate process is not limited to services provided at a facility. This is anything you might do in your office. This is anything, this is any healthcare service that's being provided and scheduled. You need to provide a good faith estimate. And I think, so I'm going to talk for just a minute about how the good faith estimate is applicable right now, and then some changes that are coming and that will be effective in January of next year. So right now, the obligation to provide the good faith estimate only applies to uninsured patients or patients who elect self-pay. So they're going to pay you out of their pocket, even if they have insurance in place. And for now, those are the only patients for which the good faith estimate obligation applies. Starting in January 1 of 2023, there will be an obligation to provide a good faith estimate for insured patients. For privately insured patients, not for Medicare, Medicaid. None of this law applies to Medicare, Medicaid patients or services provided to them. And the way that will work is if an insured patient asks a physician group for an estimate of all fees, what the practice will do is reach out to the insurance company, provide the insurance company with the information necessary about what services are being provided. And then it is the obligation of the insurance company to basically issue an EOB to the patient before services are provided, to let the patient know what the good faith, to provide the patient with that good faith estimate. So that is, again, that process for insured patients does not apply for another 8 months. So right now, I'm really talking about the good faith estimates for the uninsured or self-pay patients. There is a dispute resolution process related to situations where the billed amount are more than $400 over the estimate on the good faith estimate. So just to level set for a moment, there are 2 dispute resolution processes within the No Surprises Act. The first one that I talked about 10 slides ago relates exclusively to the situation where an out-of-network provider has provided services at a facility, and there is not a process to get consent from the patient to balance bill, so that the provider is working with the insurance company to figure out what total amount of the bill the insurance company is going to pay. So that process is limited to where you are providing services at a facility as an out-of-network provider. This dispute resolution process is invoked where you are providing services to a self-insured patient or to a patient that has elected not to use their insurance, regardless of the place that the services are provided. And the dispute resolution process can be invoked by the patient if the total bill is $400 over the estimate in the good faith estimate. The process is initiated by the patient or the patient's representative, sending notice to the Department of Health and Human Services within 120 days of receiving the initial bill. And if that notice is sent to DHHS, then DHHS appoints a selected dispute resolution entity to resolve the issue between the patient and the provider with respect to how much the total bill is and what the patient's financial responsibility should be. Now, this process does recognize that a good faith billed services can be more than a good faith estimate based on nothing that, even though the process was good on the front end. For instance, in the course of providing services, something urgent or emergent comes up that must be provided at the same time. There's other situations. So this is not a situation where you're kind of sunk. If there is a reason why the bill was for more, you get to describe that to this SDR entity and explain why the bill was more. So that wraps up the patient education portion of the presentation. I'm going to move through these next slides super fast to leave a few minutes for questions at the very end. This is a timeline of the No Surprises Act, the passage of the law, the publication of the interim and rules and regulatory guidance. This is the timeline of the provisions of the No Surprises Act that are applicable right now that you need to be complying with. One note at the very end of this slide: there is enforcement discretion right now for good faith efforts to comply with the good faith estimate, but you cannot do it because not all of the providers involved in care provided the information you needed. So for instance, you are a physician group, you have an obligation to provide the good faith estimate. You reach out to all of the other providers and facilities that may be involved in the care, and two of them just never get back to you. They're just not up to speed about what this law requires. They're just slow to get back to you, and you are running up against the deadline to provide the good faith estimate. So for the remainder of this year, it is very unlikely that you would face any scrutiny or investigation because you tried in good faith to put together that good faith estimate, but for reasons outside your control, you were not able to do so. So the timeline about what comes into place in 2023, I'll highlight the middle bullet point there, that there will be random audits of healthcare providers starting in January 1, 2023 to make sure that they're complying with the No Surprises Act. Outside of those random audits, your patients can report violations at any time that would also be subject to investigation. But even if your patients aren't reporting potential violations starting in next year, there will be random audits, much like the case with HIPAA. Who will enforce it? I'm going to skip the slide, other than to say it is a collaboration between the state and the federal government that enforces this. I will land on this slide just for a moment. This letter that was sent out by Blue Cross Blue Shield to certain hospital-based providers and emergency service providers got a lot of airplay, and I have heard about it in several presentations that I have attended about the No Surprises Act. You can actually find portions of the redacted letter online. Basically, Blue Cross Blue Shield wrote to, and this is, I'll tell you, I did not review the entirety of the letter. So this is reporting back on what I have seen or heard from other presentations or seen in the media, that Blue Cross Blue Shield wrote to certain in-network providers. So these are providers that had contracts with Blue Cross Blue Shield in place, that they could either accept lower in-network rates or that they would be kicked out of the network, where their reimbursement would be subject to the IDR arbitration process. And that IDR process at the time that this letter was sent out would have been subject to this qualifying payment amount. So the payers would kind of have known how much they would end up paying these providers under the arbitration provisions because of this qualifying payment amount. The fact that Texas case has now thrown out the qualifying payment amount, throws that, the implications of that letter potentially into a little bit of never land in terms of who holds the negotiating power and whether providers feel like that that they are not in the same situation as having to work with Blue Cross Blue Shield in response to that letter. But I will leave that at that. And if folks want to weigh in on that after questions, I'd be interested to hear, particularly providers that had to negotiate that or navigate that process and that letter have to share. These are the forms that I mentioned during the presentation. Those are going to be posted after the presentation on the website, on the North Carolina Medical Society website. So look for those after the presentation. And I believe the slide deck will be published there as well. There is the link to some of the regulations, facts, and guidance that I have cited during the presentation, including the specific link to the to the FAQs that were published in April with respect to the good faith estimates. So I will stop there. Kristen and Melissa, I have not been looking at the chat box while we've been going on. I will try to open it now. But if y'all or someone else on the call has been looking at that and wants to pose questions from the chat, that would be efficient too.
Yes, there are a number of questions. And I will say that if we don't get to all of these, or if they were not answered during the presentation, that I can work with Joy to get these answered and posted, and then and respond back to who sent them. So I'm in it. So if people will bear with me for 2 seconds while I read each question. Hospital-owned air ambulances, aren't those often covered by insurance? Yes, they are. So if the hospital is in network, typically their hospital-owned air ambulance would be in network. But lots of air ambulances are not owned by the hospital. They contract with the hospital to provide services. So you're exactly right that if it is a hospital-owned air ambulance service, and that hospital is as a participating provider, then yes, they would be covered by insurance. The uninsured is not included in the regulations. That is correct with respect to the first part of the presentation, with respect to the balanced billing prohibitions. So there is no balanced billing prohibition on uninsured patients. However, as I think I highlighted in the second part of the presentation, the good faith estimate protections really apply almost exclusively to uninsured patients at this point. How does that work when the ENT surgeon is not on call? So I'm going to need a little bit. Sandy, if we have time, or if you want to type that question again at the bottom. So are we talking about, so if an ENT surgeon is called in for an emergency service, then there would be a prohibition on balanced billing because that ENT would be providing emergency care. If you're thinking about, Sandy, something different from that, just add, specify that at the end, and hopefully I will get to that clarification when we get through these comments. Are private-owned primary care patients affected by this? I've heard different opinions. Great question. So have I. Right now, I would tell you that, so our private-owned primary care practice is affected by this. The answer is 100%, absolutely yes, all day. You are obligated as a privately owned primary care practice to comply with all of these regulations. However, if you're a privately owned practice that provides some elective procedures or cosmetic procedures, that is more of an open question that I have seen lots of different opinions on and will hopefully be addressed through further regulations. Sandy, again, if you are a non-hospital owned practice or on call, can you tell the hospital they need to take care of the patient since they are in network and you are not? The answer is no.
if nothing in the No Surprises Act changes anything with respect to your on-call obligations with respect to patients or situations where you have privileges and are required to provide services while on call. So if, for instance, the hospital, if it's an emergency service that you're called in for, then you are absolutely obligated to provide the care and are subject to the no balance billing requirements. If, however, you're called in, for instance, for a consult, and you may be able to use the consent process in order to be able to balance bill the patient if you are out of network with the hospital, with the payer, but the hospital is in network. Does primary care physicians have to post the No Surprises Act? 100%, absolutely yes. You do need to post that notice on your website and in your offices, and you also need to be providing the good faith estimate. Does the good faith estimate only have to be provided if a self-pay or an uninsured patient requests it? For now, the answer is yes. That will change as of January 1, 2023. And at that point, insured patients can request them, and you do have to provide them, but that's really done by notifying the insurance company, who would then provide basically a pre-service EOB to the patient. When does the good faith estimate have to be provided? If you only schedule same day appointments for uninsured or self-pay, or is this moot if it only needs to be provided per patient request? So there are two times that you need to provide the good faith estimate. One is at the time, if the patient requests it. And the second one is whenever a service is scheduled. So you can imagine, for instance, that a patient may call up and ask for it, a good faith estimate, even before scheduling a service with you. And if that's the case, you would have to provide it. Same thing with respect to if you need, if you're scheduling it. So same day appointments are tricky. So for urgent care, if you run an urgent care where someone actually walks in and you provide services, that is not considered a scheduled appointment. So you would not have to provide a good faith estimate for that urgent care visit. However, if as a result of that urgent care visit, you then schedule follow-up care, you would have to provide a good faith estimate. Or if you tell the individual that they're going to need follow-up care and they ask you for a good faith estimate, so they request it, even though it is not necessarily that they're going to schedule it with you, you would have to provide it then. So for same day appointments, so not urgent care, you still have to provide it 3 hours in advance. I don't know that the regulations go into this detail, but my guess is that if someone is calling for an urgent care appointment and you are scheduling it less than 3 hours in advance, that would fall under the rules of an urgent care appointment as opposed to a scheduled appointment. And so for that urgent care appointment, you would not have to provide it. Next question. If you are not part, i.e. owned by the hospital facility, you do not have access to those rates. We typically refer them to the facility. Are you saying we need to do this? Yes, you have to reach out to the hospital for the uninsured and self-pay patients and request the hospital provide you with those rates, and then you put it in your good faith estimate. The hospital is supposed to provide that to you within 1 business day. Next question. As ophthalmologists, we may be contracted with patient's medical plan, but we don't participate with the vision plan. This patient is responsible to pay for the routine vision service, but they can submit bill to plan for reimbursement. Would these patients require a good faith estimate? I think the answer is yes, and that it would. And again, I'm going to say, unlike above, where I think I've answered the question fairly emphatically, yes or no. I think, Cheryl, the best answer to this one would be to provide the good faith estimate, but to note that the portions of it that are the patient's responsibility My guess is that you're already providing those advanced beneficiary notice type provision notices to Medicare, Medicaid patients. So I would guess that it would look a whole lot like an ABN for those vision services. Cheryl, I am not 100% confident in that answer, though. Just based on what I know, that's what I think. But I'd encourage you to follow up with someone to make sure that that is the right answer with respect to the routine vision services. Can the good faith estimate be a range or a statement that costs will not be more than X versus an actual amount? That is an excellent question that I do not know the answer to, but I will find out and I will follow up. I will try to find the answer to that, and maybe Melissa. I mean, that's one where there should be an answer to it, and I just don't know the answer off the top of my head. And I will try to find that and see if Kristen or Melissa can publish that when we get the information out on the medical board website. And Kristen and Melissa, I'm doing a screenshot of this, so I remember to ask, get to that. But if you will remind me as well, that would be awesome. So as a pediatrician, if I refer to ENT to put tubes in, I need to be the one providing a GFE on cost of the surgery. The answer is no, because you're not involved in that. You have, I guess it has to be the person that is providing the service. One of the service providers is the one providing the good faith estimate. So if you are merely referring to someone to a specialist, they need to ask the specialist for the good faith estimate. Or if, for instance, they know it's going to be provided at an ambulatory surgery center, they could reach out to the ambulatory surgery center. I guess a rule of thumb is if you're not going to have a cost entry on that good faith estimate, then you're not the one that is obligated to provide the good faith estimate. Are primary care practices required to provide good faith estimates to all uninsured patients for regular office visits, or just when asked, or just when procedures are being scheduled? The answer is all regular office visits. Okay, I'm sorry that you could not see the speaker. I think that my camera is turned off because the presentation was up. And let me see if I stop sharing, if you can now see me. I don't know what the answer to that was. Let's see. Well, anyway, I'm going to move on. Maybe you can see me now and maybe you can't. Will office-based providers be required to provide outside lab costs when ordered, for example, from LabCorp? The answer is yes. You would, if you know that lab services are going to be part of the service that you're ordering, then yes, you need to reach out to LabCorp, and LabCorp needs to provide you with that estimate for the cost of the services within 1 business day. If we schedule ortho surgery, is it the expectation that we have to get the hospital estimate along with the anesthesia cost? Yes, you are required to get those. However, as I put in the slide, there is, as long as there's a good faith attempt to provide good faith estimates, there is unlikely to be enforcement provisions if you cannot get those facility costs or the anesthesia costs this year. However, starting next year, you do have to include those in your good faith estimates. Okay, last question I see right now. Can you clarify if an independent practice is out of network for an insurance and provides the service in office, would we have to follow the out of network billing guideline portion? The answer is no. The provisions in my presentation that related to the prohibition on out of network billing and out of network billing and balance billing only apply to services provided at a facility. They do not provide to services provided in your physician practice, for instance. You can balance bill the patient. However, remember that you have provided, if that patient is self-insured or is not insured, you've provided them with a good faith estimate as well. Do we have to have a patient sign a good faith estimate every visit when they are self-pay? The answer is no. There is a way, and I believe it's even in the CMS form, that if you, for instance, have someone that comes in for allergy shots or something where they are routinely coming in to have a specific type of visit, you can tailor the good faith estimate to provide them, to say that this applies to, every visit that you're going to have for allergy shots for the next 6 months or something like that. So you would not have to provide them with one for every visit when they come in. Okay. I am 6 minutes over, but Melissa and Kristen, I think that wraps it up, the questions online. So I'm going to stop there.
It does. Thank you very much. And I will try to take some of those questions and put an FAQ together and post that as well so that people can see all that. And thank you everyone for joining us, and especially thank you to Joy for doing this. This was a very, very informative presentation. I appreciate you taking the time today. It was really well done. Thank you very much.
Happy to do it. Thanks.
All right. Everybody, I will have these posted on the NCMS website, and we'll send it out through our morning rounds, as well as work with the NCMGMA to post on through their blog. However, if you have any questions, feel free to reach out to us, and we're happy to provide those for you. Okay. Thank you, everyone, and have a great day.